We're having a really nice
Good.
discussion. So
Yeah, actually, it's funny that you say that because that's exactly how it happened, right? So they found that they were going too low, and initially they considered it a failure, but then they were like, well, wait a second, this actually looks not too bad, and then they realized that they could target this area on an ongoing basis. So so I think what we wanted to do today, as we've been doing with a lot of these sessions, is we just want to go over, once again, the basic technique. And then I think, Jackie, you're going to do a bit of a journal club, sort of present, our initial publication, actually, of our experience, and then, just have an open discussion of and answer any questions from people who may either be doing it or want to start doing it. So maybe, Jackie, should I just try sharing the screen? And
yeah, I think you can.
yeah, here it is. Okay.
Okay.
Okay, so these are slides that I give credit to Dr. Santosh Padala from Virginia Commonwealth University. He's the one who created these slides, and I don't want to pretend that I'm the one who created these when I did not. But he was kind enough to allow us to use them on an ongoing basis. So in terms of left bundle pacing implantation, right now the tools that are available are basically the Medtronic 3830 lead. And I'm sure most of you already are familiar with this lead, but for those of you who are not, it is a small 4 French lead that basically has a tined active fix component to it. But unlike other leads, you rotate the entire lead in order to fix the lead. So it's not like the tine comes in and out with a screw mechanism. You just screw the entire lead to get it to fix. There is a fixed His catheter sheath that can be used. And now in Canada, there's also the deflectable His catheter. To be honest, even though the deflectable became available, I never use it. I still go almost 100% with the fixed sheath, and I use a stiff Amplatzer guide wire which can change the shape of the sheath. So using the wire, you can often get the sheath to get more reach or to change the shape in order to reach where you want to get to. So I've actually never really, I used it a couple of times in the beginning, and then I went back to the fixed sheath.
Atul, I don't think that's a 3830 lead.
This one?
Yeah, that looks like that's an active fixed screw. It's not a fixed screw, it's a retractable screw.
Yeah, it might be.
Just so you can tell him that he needs to update his slides.
Okay, all right, I'll let him know. I thought this would, yeah, good point. I guess it helps to be the head of the device committee of the CHRS. You notice these little things. Conduction system pacing. So this is an MRI generated view of the conduction system, where they segmented out all the components of the conduction system. So up here, you basically have the His bundle. The His bundle then breaks into the right bundle and the left bundle, and then distally they kind of branch out into this fine web of conduction system that supplies the rest of the heart. And so obviously His bundle pacing is sort of the first type of physiologic pacing that was described, and that was sort of the classic physiologic pacing. But now left bundle pacing, and one of the advantages is that you can see here the His is very, very small. So you kind of have to hit that target right on. Whereas the left bundle has quite a bit of runway here. So even if you don't quite hit the left bundle in exactly the right spot, there are actually many potential spots where you can get quite good left bundle pacing, and that's one of the advantages of the technique. In terms of block, I mean, a lot of people say, well, you know, if I screw something into the left bundle, how do I know that if the patient already has left bundle branch block, that the block won't be distal to wherever I screw my lead? And the answer is you don't know for sure. But one of the observations that has been made, and this is actually a nice paper by Sam Asivatham, is that oftentimes the block is a little bit more proximal. And even if there is more diffuse disease along either the left bundle or the right bundle, unlike the His bundle where you're sort of forced to go into this fairly narrow area where the block may be, you know, affecting most of the bundle, as you get further down, the disease may be a little bit more diffuse. So even though screwing into this part of the left bundle may not give you an optimal result, you can screw into many different parts of the left bundle, and you're more likely to get around that site of block. So in general, this is the technique. This is basically the overview. So when you're first starting, we usually recommend to actually locate the His and then do a cine shot to save that for a reference. And then what you're going to do is you're actually going to move 1.5 to 2 centimeters distal to the His to get to the left bundle. Once you get your lead to the left bundle, you should pace map. And ideally, you should have a so-called W pattern in V1 initially, where you have a little hump in the middle of your electrogram. And you should have a septal morphology where lead 2 is greater than lead 3 in terms of height, and there is discordance between leads AVL and AVR. And if there is an acceptable morphology, then you can start rotating the lead and noting the pacing impedance and then determining whether you have actually got optimal selective left bundle pacing. Now, a lot of you, I don't know, for those of you who are doing a lot of this, like for example, Larry, Klaus, Jackie, do you still map the His first, or do you just go to the left bundle now?
I don't map anymore.
Okay.
I always do. I spend a couple of minutes. I've found a few times where I've been trying to get into the left bundle, and then I go back, I find the His, and I move, and it's helped a few times. I was clearly off. You know, I sort of guessed, but
Yeah, I mean, I
I
think
don't
that
spend hours, but I spend a few minutes.
I feel like the sheath just drops right in that spot usually, so it's really not that hard. But or if you're having a difficult case, you know where your landmark is. Yes. Yeah.
I mean, some
Yeah.
people suggest just injecting a bit of dye across the tricuspid valve, and then you have a sort of anatomical, you know, okay, I know where the tricuspid annulus is, I know where the apex of that is.
So I'm going also to just the left bundle, but usually the problem is when the right atrium is quite dilated, this introducer tries to very easily go into the coronary sinus. So lately, especially if it's a DDD system, I put the atrial lead first, and the curve gives me an idea that I should be lower than that. If my catheter is septal, but it's still, you know, at the atrial lead level, I should go even lower. So It's the only, if I do nothing and the right atrium is dilated, it usually end up in the, very easily in the coronary sinus.
Yeah, thanks for that. It's actually, by the way, a great coronary sinus catheter. So we've had some difficult coronary sinus cases where I've actually pulled the His bundle sheath, and it's very nicely delivered the lead into the coronary sinus when we're doing a CRT. But basically, as you can see here, you want to go distal to that site of the His, and I have to admit, I no longer map the His. I just go to the left bundle position. It's ideal to do this in an RAO 10. That's a great view for doing this, and then you'll sort of get a very nice view. It'll splay out that septum very well, and this is the kind of direction you want to go in. Again, if you use a very stiff guide wire like an Amplatzer guide wire through this, it will also usually stretch it. So if you don't have a guide wire in and you just advance the sheath, it's naturally going to want to go up to the His position. That's what it was designed for. But if you put a stiff guide wire in, it stretches it down, and it almost always just delivers into this left bundle position. Basically, you know, this is just showing how if the person happens to have a mechanical aortic or mitral valve, that can sometimes help you in locating both the His as well as the left bundle position. Because as you can see here in the His potential location, you know, they're closer to the valve annulus, whereas here, you know, in the left bundle position, they're clearly distal to that position. So sometimes you can use other anatomical landmarks to help you. One of the big things is to make sure that your sheath actually has a little bit of counterclockwise torque on it. So even when you're using a wire or whatever it is, and you get the sheath into that septal position, which is very nice, it's very important to put a little bit of counterclockwise torque on it, because that will really force your lead to go into the septum and not go more to the anterior septum, or sometimes, very rarely, you can even be pointing out towards the free wall, which is very, very rare. But if you're got a little bit of that counterclockwise rotation on it, it really, really helps. And in the beginning, I know that I wasn't being very anal about doing that, and you know, my results were a little bit more unpredictable. But once I started getting really obsessive compulsive about putting that little bit of counterclockwise turn, it really helped for me personally.
Atul,
Yeah.
just a quick question. I'm sure I've asked you this before, but in addition to your 10 of RAO, do you ever use 40 of LAO to see if it's pointing towards the spine to really confirm you're not heading anterior?
Absolutely. Absolutely. You're right on, Sean. So I was going to get to that, but
Okay.
RAO 10 is absolutely the sort of view that you would use to initially place. But absolutely, LAO 30 is a great, you don't even have to go LAO 40, like even LAO 30 is a great way to confirm that you're pointing to the spine and that you're going septally. And when we get to the part of the septogram, usually the septogram is performed in the LAO 30 view to confirm how much of your lead is actually buried in the septum. So usually this takes, especially when you're starting, this takes an assistant. You're not going to be able to do all of this alone. And often you need to get the assistant to hold that sheath in place to maintain that counterclockwise torque. Now, as you get better at doing this, you learn to kind of do everything by yourself, and you can sort of, with some of your fingers do the counterclocking, other fingers do the rotating, and you kind of become like an octopus. But in the beginning, don't be afraid to ask for assistance. Then generally speaking, you're only going to be rotating the lead 4 or 5 times. So early on in the left bundle experience, there were some publications that suggested you need to turn the lead like 30 or 40 or 50 times. And if you're turning the lead that many times, then you're probably hitting the left bundle of your next patient in the waiting room. You know, you don't need to turn the lead that many times at all. And in fact, if you rotate quite slowly, and I'm going to show you a video where Santosh is doing this with a two-handed technique, you're going to get far more bang for your buck than if you're just trying to rotate it very, very quickly with one hand. And so I'll just sort of go into a more detailed here. So this is the rotation technique, and you know, he's purposely showing his gloves, and I know this is sounds like a bit of a minor point, but I always wash my hands and dry them off before I do the rotation, because it really does help in terms of getting a good grip on the lead and rotating the lead. And you'll see that it is a two-handed technique, and you're turning the lead with both hands simultaneously, one close to the hub of the sheath and the other one a little further back. And you want to use that two-handed technique for rotating the lead. And here he's actually kind of rotating it a lot faster than I do it, and I'd be interested to hear from other people. But I've actually found that over time I've slowed down my rotations, because I find that if there is some scar or fibrosis in the septum, you're more likely to dig through it by doing a very careful, gentle, but forward pressing rotation rather than trying to turn it really, really fast. I don't know if other people have a comment about that.
I have a comment, Felix.
Go ahead,
So,
Felix. Yep.
I have modified a little my techniques in the last year. So I usually now I pre-charge the lead in the introducer, and before putting all, you know, the lead and the introducer inside the body, I just make all the turns. So I want to be sure that when I'm applying, you know, when I'm turning inside, it's already transmitting the torque through the muscle. So it takes like, you know, 4 or 5 turns before you are transmitting your outside movement to the tip of the. So I do it just with everything out. So once I see that my lead is turning already, I put everything out. Actually, it helps me to make it a little stiffer also, as you mentioned, with instead of putting a wire, I just put my lead inside. And it saves me some fluoroscopy. I don't like fluoroscopy, you know, already. So saves me some like 1 or 2 minutes of fluoroscopy, because I know that once I'm in there, I start turning. And the other thing, if it is not advancing, if you have recoil, I change the place. I don't know why, but most of the times, if the lead is not advancing, you know, smooth, there's something wrong. Most of cases, I think I'm doing too much over torquing and I'm going too posterior. So probably just hitting the pericardium already. So it should be smooth. When everything is fine and goes fast, it's, as you told, small, 5, 6, 7, 8, whatever, but with no turning back, so that's what I've seen.
Yeah, that's a great point, Felix, that if you're hitting a lot of resistance and you really have a very fibrotic septum, it is probably a good idea to just change your position. And not only change the position, but remember to bring back your lead and clean the tissue out of the helix. Because if your helix is full of a tissue biopsy, then it's not going to be able to dig into the tissue. I actually like this idea. I'm going to try it, Felix, of pre-rotating the lead to make sure that the transmission is already there. One of the things that I sometimes do to transmit is, let's say I do 1 or 2 turns and I'm starting to get a bit of recoil. What I'll do is I'll just push the lead in and out just a tiny bit. I'll stop rotating and I'll just push the lead in and out, like kind of like this motion. And that will help to transmit any built up torque to the tip of the lead. So I'll often see that the lead is not necessarily going in when I'm just turning, but when I do that little movement, it will transmit the torque to the end of the lead. So as we mentioned, when you're pacing, and this is unipolar pacing. So for those people who are not familiar with this, first you're unipolar pacing. So it means you can clamp your proximal end to the tip of the lead and your distal clip to the skin. And this will give you unipolar pacing, and you want to get this sort of W pattern. And when you look at AVL and AVR, you want the initial deflections to be in the opposite direction. So the initial deflection of AVL is positive. The initial deflection of AVR is negative. They are dissociated. So this is a pretty good, reasonable first look at your pattern. So then after you do a few turns, so in this case, maybe 3 or 4 turns, what you'll notice is that this notch actually starts to move further in the electrogram. So this kind of asymmetric W becomes more of a symmetric W. And then eventually what's going to happen is this notch is actually going to end up at the end of your local electrogram like this. And you'll notice that the deeper you go, your QRS should be getting narrower and narrower, and there should be more and more latency between the pacing spike and the beginning of your QRS. So here, you're starting to see a little bit more latency. The notch is moving to the right, the QRS is decreasing. But you know when that notch comes here and you have that QR pattern, you have a long latency, and suddenly the QRS duration decreases to 115, you know that you've hit that sweet spot. So, you know, if you need to rotate further, you can. Typically, it's about, you know, on average 6 to 12 turns. And then, as Sean pointed out, you know, the LAO 30 is a great way to confirm that you're septal. And this is also the position where you would do your septogram in order to confirm how deep your lead is in the septum. So just as a way of measuring, the helix is about 1.8 millimeters. The tip of the electrode to the beginning of the ring electrode is 9 millimeters, and the ring electrode is 3.8 millimeters. So when you add everything up, if you go from the tip of the helix to the proximal end of this proximal electrode, that's about 1.8 centimeters. And so if you know that that's 1.8 centimeters, then in this case, here we have an LAO 30. You can see the lead is pointing towards the spine, so clearly he's septal. You just bring back your sheath to make sure the sheath is not in the septum, because sometimes as you're screwing, the sheath can go in the septum and you don't want to inject dye into the septum. So pull your sheath back a little bit, inject your little bit of dye, and you can clearly see here that this is probably about 1.2 centimeters buried in the septum. If the proximal ring was also in there, then it would have been 1.8. So again, very nice way to demonstrate how deep you are into the lead. And these are some other examples of septograms. So I'll just play them for you. But you know, ugh. These are terrible septograms. All right, I'm just going to skip over this. This looks very frightening. Okay, so unipolar pacing from the tip. and unipolar pacing from the ring. So if you want to confirm if your ring is actually in contact with the tissue and if you're getting any capture from your ring, you can just move your alligator clip from the tip to the ring. And of course, from the tip, you'll have, you know, beautiful, typical QR narrow pacing. But when you start pacing from the ring, you're going to get more of this QS, maybe a notch type pattern that you would have passed on your way into the septum. So what do you do if the lead buckles or backspins? And I think we've already talked about that, and Felix said it very nicely. Go somewhere else. You know, so you can try my little tricks of going slower and transmitting the force at the tip of the lead. But if that doesn't work, go somewhere else, try a different position. And remember, before repositioning it, make sure you take it out of your sheath and clean the helix, because sometimes you'll see this. And if this is at the tip of your helix, that's never going to screw into anything. So I find that using your scalpel blade is the easiest way to clean this off. It's very simple, very easy. You know, trying to use your fingers or tweezers or other things, it becomes really finicky. If you use a scalpel blade, and provided you don't slice your lead, it works really, really well. So how do you know when you should be giving more turns? In other words, how do you know that you're done? Okay. And I really like this because here Santosh is comparing the left ventricular activation time, or the LVAT, which is the distance from the pacing spike to the peak of V5. I usually use V5 to measure this. And you can compare it when you're doing high output pacing, where you're more likely to be capturing the left bundle, but compare it to low output pacing, where you really have to selectively be in the left bundle to capture it, right? So in this case, you can see that at high voltage, the LVAT is good. It's 65 milliseconds. You want it to be less than 80 or 85 milliseconds. But when you pace at lower output, you can see the LVAT is much worse. So that means you're close to the left bundle, you're capturing it with a higher output, but you're not quite there because you lose it when you go at a lower output. So if you do one more turn in this case, you see that not only do you have an excellent LVAT at 5 volts, but you continue to have a very good LVAT when you're only at 1 volt. So it means you're selectively capturing the left bundle. Another way that you can try to understand when to stop rotating the lead is if you happen to have a left bundle potential and you actually see injury on the left bundle potential. And I'll tell you, this is rare as hen's teeth. I don't know, Felix, Jackie, Larry, Klaus, how often you've seen this. Maybe I've seen it, but I just didn't notice it. I haven't seen it. But, you know, if you see something like this, it means you're really in the left bundle.
Yeah, I've only seen it once, but where I've nailed it.
Yeah, so you're a much better operator than I, Klaus, because I've never
luck,
seen
you know,
it.
I mean, it's just sort of gave. In fact, I thought, well, geez, where am I exactly? It was so big. I thought it was a hiss, but it didn't make any sense. I wasn't pacing the hiss, but.
Did you capture that? Like, do you have a tracing of that?
No, I wish I did. You know, some days I save all kinds of stuff, but see, we don't have that would be the stupid paper out of the analyzer, so it's not very.
Oh, okay, all right.
Yeah, it doesn't.
So
well,
it's not one of those big fish stories, is it? Like I caught a fish last
really,
weekend,
really,
so big, but then
yeah.
I threw it back and I never took a picture of it. Is that?
Yeah, something like that. Yeah.
Yeah. Okay. All right.
But your point is, it's not very common. So
Yeah.
for those people who do it in a proper EP lab and use nicer equipment than just the analyzer, do you see left bundle potentials a lot more often?
No. I'll see it depends. Like, sometimes I'll see something that looks like a left bundle potential, but unless it's really high frequency and the appropriate, distance away from the local electrogram, I have a very high threshold for calling something a left bundle potential. But for example, when Santosh was up doing cases with us, like he was like, oh, look, there's a left bundle potential. And I was kind of like, I don't know about that. So I think some people, I don't see it more often than about 20 or 30% of the time. I don't know if other people want to comment on that.
I have to admit, I don't look very much because I really take a look at the paste impedance and the paste QRSs. Although the change in vector, I think that was mentioned on there as well, I do see that frequently.
This?
I've been challenged by the
Clarity,
cost
yeah.
of things. So just the cable, which is one use, is like $100, so half the cost of introducers. I'm no longer using the Sitka or whatever cable Medtronic just to diminish cost. So I'm using just the standard cable you use for a standard pacemaker. So I'm not taking a look anymore on the if there's or not a left bundle potential. One comment. So I used to pace always unipolar and then bipolar. Usually again, so bipolar or the sorry, the ring should be giving you a left bundle branch block morphology. But sometimes I don't know what to do when in bipolar I have the same morphology as in unipolar. So everything is fine, impedance is still okay, you have a great threshold. But in bipolar, I have the same QRSs. Most of cases, I just, I left the lead in place and I hope it's not too far. But what do you think? So if you have the same configuration in bipolar than in unipolar, is that too far? Do you undo the turns or?
Is that at a low voltage output?
Yes, I mean,
would say it's more common to have the same.
So what they say is, it's that morphology, that look can actually be described as occurring because either there's like anatomic variations, maybe the hiss is on the other side, or there's some electrode effect happening, but also there's maybe fascicles or little areas that are connecting the right and left bundles a little bit more proximally. Or it's like retrograde conduction up to the hiss and then back down the bundles. So there's some suspicion that it's because of those, things, I think, but that's not a totally uncommon morphology, I would say. I mean,
yeah, I would agree with that. So that's where I would look at, the QRS width. I would look at the overall pace morphology, the LVAT, the left ventricular activation time. And then if there is VA conduction, and we'll talk about that, confirming that VA conduction at higher output, VA conduction from the tip versus VA conduction from the ring, to look at those different factors as well. But it's not uncommon. So this was what Larry was talking about, the drop in impedance, right? So, as you screw towards the left bundle, these impedances are a little bit low, but usually with a unipolar impedance, your opening impedance can be quite high. It can be 1100, 1200, 1300 ohms. But as you screw slowly towards the left bundle, the impedance will sort of either rise a little bit or it won't change very much. but as soon as you get into the left bundle, you'll notice a sudden drop in the impedance. And this is also pretty dramatic. I often don't see this dramatic a drop in the impedance. Usually it may go, let's say, from 1300 to 1100, or 1300 to 1000. It's not necessarily going to half like this, where it goes from 700 to 300. But the change in impedance, the drop in impedance, is another indicator that you've hit the right spot.
Well, he's hit the left ventricle, though, I think, hasn't he?
Well, I was also saying the polarity change. So you look at the injury current as you're going across, and it's sort of that upright injury current, and suddenly you lose the upright injury current. That's where I
you're usually through.
But that usually means, now you're there.
I would say I'm close to be the other side, but anyways, I'm very.
So Larry, you don't think you're in the lot? You're through?
You know what? I will then check. I'll see what the threshold is unipolar. I'll see what the impedance does, and often the impedance has dropped by 10 to 15%, but it's pacing fine and the threshold's good. When I go through, and I've done it, I find that the impedance goes right off. It just doesn't capture anymore, unipolar.
Yeah. Well, just one comment. When I'm aiming now much lower, so 2 centimeters, especially in all ladies, I've seen that the upper septum is quite thin, and it's not that difficult especially if your bleed is not horizontal. It's a little slightly, going up. It's quite fast. You are in the other side, and you are already stimulating or capturing the lateral outflow tract, left lateral outflow tract. So especially in all ladies, I try to go as 2 centimeters, even a little lower than that, and be sure that the bleed is going in this direction instead of slightly that, because quite easy to be the other side.
That's good info, Felix. I agree. And I also agree with you, Larry, that, once you're through and through, you don't capture at all. Like it's not a subtle thing. When you screw through the septum, you're not capturing at all. Like it's a pretty dramatic thing.
I have a video that I will ask if I can borrow and share of the 3830 lead freely floating in the left ventricle on one where it went a little too far. So once it does go through, it does seem to then just slide out.
It didn't go to the
slide where it's Vidal here. The slide where the impedance halves, isn't that meant to say that you've gone too much? Like if the impedance drops so much, I'd be concerned, I think, no? Or is this slide meant to say that's a good spot, or that's you've gone
no, usually it means it's a good spot. So if the impedance has gone, and these are not typical numbers, like as I was saying, your typical opening impedance will usually be around 11 to 1300 ohms. And then if it drops down to, let's say it's 1300 and it drops, usually the drop will be to 1100 or to 1000. If it's dropping from 1300 to 100, there's something wrong. I mean, that's but it's that smaller drop that you're looking for that gives you an indication you're in the right spot, along with all the other criteria, of course. Speaking of which, these are the criteria for left bundle capture. So seeing a paced morphology of a right bundle branch pattern, typically a QR pattern or an RSR prime pattern would be the ideal. If you can, identification of the left bundle potential. We talked about the left ventricular activation time and measuring the pacing stimulus to the LVAT and making sure that the LVAT at high output is similar to the LVAT at low output. Determination of selective versus non-selective left bundle pacing, and then evidence for direct left bundle capture. So these are the 5 criteria. And in practice, you usually would like to have 2 of these criteria in order to confirm left bundle capture. So in terms of the pace morphology, the QR or the RSR pattern, I think I've already shown this where, you know, we usually, for those of you who do have a recording system, we'll usually put V1 at the bottom, right above the local electrograms, and space it apart from all the other leads so that you can clearly see the morphology in V1, because that's the lead where you're really focusing on. And then we'll also put AVR and AVL right together and put them in different colors, like yellow and blue, so that they really stand out and you can confirm that there's dissociation of AVL and AVR. So those are just some little tricks that you can use to help you, you know, your eyes trigger on the right parts of the ECG. So this morphology is sort of the ideal morphology, a long latency, a QR pattern, although we can talk about different patterns. And the latency is usually in the range of about 30 milliseconds if you measure it. Left bundle potentials, you know, if you see them, great, that's wonderful, that's terrific. If you see a left bundle potential with huge injury, it's like the big fish that got away, but you still tell the story. You know, sometimes you'll be lucky if you see that kind of injury, and sometimes with a PVC, you may even see the retrograde left bundle potential as well, which is really, this is a very nice tracing. I really like this tracing. So again, you want to make sure that the LVAT time is similar at high and low outputs. So you measure basically the stim to the peak of V5, and you can see here that whether you're pacing at 10 volts, 5 volts, or 1 volt, the LVAT is very, very consistent. The number should be under 85 to 90 milliseconds to know that you're really in the right spot. You can look for evidence of non-selective to selective left bundle pacing during bipolar pacing. So what you do during bipolar pacing is you'll start at a high output, let's say at 5 volts, and then you'll slowly come down. And this is the key, you have to come down slowly, because if you come down too quickly, you may miss the transition point. And for example, the transition point is usually between 2.5 and 3.5 volts. So, you know, at some point you'll see this non-selective left bundle capture at the higher output, and then all of a sudden your morphology will change and you'll actually see more latency between the local electrogram and the local spike. So here you can see the electrogram is almost pushed right up against the spike, and all of a sudden the electrogram kind of moves out a little bit. You get a little bit of latency, your morphology changes, and this indicates the transition from non-selective to selective left bundle pacing. Okay, so evidence of direct left bundle capture. So again, here you can look at the VA time, and again, you can pace from the ring electrode as well as from the tip electrode. And what you'll see here is that when you pace from the unipolar ring, you have evidence of non-selective capture or capture outside of the left bundle. So you see sort of this W notch morphology, you see a wider QRS duration, but when you pace from the tip of your lead, suddenly the QRS duration narrows considerably. You now have latency between the stim and the local electrogram, which you didn't have here, and you now have this beautiful QR morphology. So this is evidence of direct versus indirect, indirect versus direct left bundle stimulation. In terms of VA times, this is another evidence that you are actually, you've got selective left bundle capture. So when you're pacing in the V, provided that you have intact VA conduction, which obviously you're not always going to have, because some of these patients are going to have heart block, conduction system disease. So you may not have VA conduction, but if you do have VA conduction, you can see a longer VA time when you're pacing from the ring compared to when you're pacing from the tip. All right, so I actually just looked at the time and I didn't realize that I was going on for way too long. So I'm gonna actually stop there and stop sharing, and maybe open it up to any questions. And then, you know, if there's anybody, Jackie, if you want to present the journal club, by all means. But sorry for taking so long.
That was great, Atul. Thank you. I'm sorry, I've got an administrative meeting that I got to leave for in a couple of minutes. But the one question I wanted to ask about were the acute threshold rises with this. I've seen a few situations where we've gone in and we've had a, you know, initially it's not too bad, the threshold, but as I'm closing, I can see the threshold go up to 3.5 volts. But by the time I finished closing, you know, 5 minutes later, yes, I'm a slow sewer. The threshold's back down again to about 1.5 volts without touching the leads. Has anybody else seen that? When you and I talked to Atul about it, you said I might be a little high, and I think you're right. In some cases, it seems to happen more if I'm higher up than if I'm closer to the apex, but I've seen it quite a few times.
Yeah, I think it happens when you're a little bit higher, closer to the hiss. But the other thing is, you know, there are some patients who just have a really marked inflammatory response when you screw that lead into the septum. And so I have seen some cases where initially the threshold is quite high. Like when I test the unipolar threshold, I'll get a threshold of 2.8. And, you know, I'll sort of be disappointed, and the nurses will be like, are you sure you want to leave the lead there? But then you just wait for about 2 or 3 minutes and suddenly the threshold drops to 1.1. So there seems to be quite a marked, you know, inflammatory response in some of these patients. And remember, you know, these are not like our typical steroid eluting leads, right, that we're used to. This lead is much simpler in its design, and one of the things actually that Medtronic is thinking of working on is putting more steroid elution on this lead, or finding ways of mimicking steroid elution using different metallic compounds with the lead. So you know, I think there are some patients where there's a marked inflammatory response, Larry.
Atul, you know, we have, you know, a number of us provided some cases. Maybe, you know, do you want to skip the journal club? Do you want to do the journal club quick and then we could look at the cases, or what do you think? Because they're really great.
Yeah, no, if people have cases, I think that's much better than a journal club. Yeah.
I was just curious if how many people are using the fixed versus the deflectable. I don't know. I started a little after you, obviously, Atul, and shortly after I started, the deflectable one came, and I just use it all the time. I don't know. It seems to work fine. I don't know what people use.
I use the fixed. Felix?
I'm using fixed. I've used twice only the deflectable, and especially when the right atrium is too dilated. And actually, I tried 2 weeks ago. They're already approved in Canada the Biotronic. They have 3 different curves, fixed. But then you have, even for dilated atrium, you can use the biggest one, and it's more than enough. So
just use one. I don't know, you know, and deflect it. I guess maybe I've missed an advantage, you know, because I only used the other one a few times, and then I just said, oh, this fancy new one came along. And it seems to work.
Jackie, what do you do?
Yeah, I'd switch to the deflectable to get in those big, you know, those big hearts. You know, I know you use the like an implants or whatever, but I don't know. I use the deflectable usually. It's not often though, you know. I think in,
Claire.
you know, your series, I think, you know, overall it improved the success rate from about 80% to like 90%, you know. So there's a little bit increased chance of success with it. But that might be, you know, maybe with a little bit less experience early on, I'm not sure.
I've been using the fixed for all of them as well. I tried the deflectable a couple times and didn't find it had enough pointing towards the septum. It seemed to be a little more open tip, and it kept giving me a more superior angle. So I used the fixed with the trick of using the Amplatz wire to really stuff it down towards the apex, crank it over, pull the wire out, and it usually sticks pretty well down there.
I've been using the fixed as well. I use it over a Terumo though. I don't know if you think that the stiffer wire gets you further, but I find that some tall patients or large atrium, I find it's kind of short. I'm pushing it in all the way in, and then I'm butting against a sheath. Sometimes I feel like I'd prefer a longer sheath.
Yeah, that's true, but I don't think that gets solved by using the deflectable. There's
the same length, right? I think we need some longer.
Yeah,
sheath
you definitely. There's ones where I've just run out of catheter.
Is there a big difference in the ability to remove them? You know, like the difference between the CRT catheters, the braided deflectable ones were really quite tough and challenging to slit, as opposed to the fixed shape ones.
I will tell you, having used it all the time, you have to be very careful not to rotate, because the wire, if you rotate around a little bit, if your hand wavers, you get into the wire that deflects it, and that's a bugger. So, but once you've learned that trick, you have to keep exactly on the opposite plane from the inside curve, and then you stay away. Then it's the same as. But if you're not careful, you'll hit the wire.
Yeah, the fixed is very easy to slit. But, you know, I think as Klaus said, once you get used to splitting the deflectable, I don't think that's a big difference.
No. Yeah, I think it's, I was just slightly confused the first few times I did it.
Okay.
Francois, I don't know if you have anything to add. Are you doing a lot of left bundle pacing, and do you have anything to add?
We're doing more and more. I think we had the same challenges as the one you discussed, being too high at the beginning. I think that was probably my first mistake, was going too high, because the sheet wants you to go too high, because I don't think we have the perfect tool yet to do it. I use the fixed one as you suggested, and I think it's easier. Otherwise, I think all the comments and the tips and tricks, that's what we're dealing with every day also. So yeah, we're doing more and more. We're more implanters now doing it also. Our fellows like it too.
Great. Okay. So can you guys see my screen or no?
No.
No, you can't? Okay. Let me see. And now, yeah, all good?
Yeah, now, yes.
Okay, cool. All right, so I think the first one are from Klaus. Okay, so maybe Klaus, do you mind maybe just narrating through your slides?
This was just doing a threshold, 12 leads. It's in bipolar, going you know, from higher to lower, and you can see if you look in V1 that, you know, you don't have an R wave, and then suddenly you get the classic R wave. Obviously, this is the follow-up, not during implant. And so halfway through, you're getting that. Now, you know, I think the mechanism of that, I mean, there could be multiple mechanisms, but it's quite common to see, you know. So if you don't see an R prime, there's multiple reasons. One is you may not get it. I mean, 10 or 15 50% of patients, you just get a QS, very narrow QS in V1. In fact, that is a very narrow one. Here, you know, so the question is this capture of the right bundle with the ring? Is it some interconnections? Is it just myocardial capture near the base that heads up to the, you know, wherever the R prime comes, I assume, from you guys who map hearts? I guess I don't do EP studies, but so whether it's just myocardial depolarization, muscle to muscle, depolarizing that area at the base, you know, in the outflow kind of area. So I don't know, what do you guys think is the mechanism of this? Because it's not really like this is going from non-selective to selective.
I think
there's no change in latency.
Right. I think what's happening though is, and this occurred like a few weeks after the implant?
Yeah, we see this all the time. During the implant, after the implant, very, very commonly. Because we've commonly do it in unipolar and bipolar, just, I don't know, just because not for any good reason.
I think
you see it very frequently.
Yeah, I think it's because the septal myocardial capture, like that anodal, you know, area, that threshold decreases with time, and so what you're left with is the more selective, you know, look. That's what I think. I don't know what you think, Atul, or.
Yeah, I mean, you know, everyone calls this loss of anodal stim, you know, like Huang and Padala and everyone. So, you know, the mechanism of going from the QS to the QR, you know, supposedly is, you know, as you go down on the output and you're doing your threshold, you know, the anode, basically, you lose stimulation off of the anode, which is more susceptible because supposedly it's, you know, not selectively in the left bundle. Part of it may actually be sticking out. So there's a number of different explanations, but, you know, the terminology, whether it's true or not, the terminology that people seem to use is the loss of anodal stim.
Yeah. But I think, too, partly the point is, if you just do a 12-lead ECG, you often don't see an R prime because you're at a higher output, you know, you're relatively higher. So it's not, in follow-up, you don't necessarily see that classic R prime in V1. You may have, quotes, lost it.
It also, you know, suggests that you really have to take care, you know, during follow-up of these patients too. Probably an ECG is really important during follow-up, you know, because otherwise your pacemaker nurses will just kind of see the patient and then move on, and maybe, you know, extend out your, you know, AV delays and, you know, put MVP pacing on or whatever. And so you end up like losing this whole beautiful pacing result, right? Or they increase the thresholds or whatever. So I think that's a testament to the fact that I think we need to do ECGs during the follow-up.
Yeah,
I certainly have seen ones though where you know, the rare one, because sometimes the higher output is significantly narrower. So maybe we are capturing the right bundle, but that's the rare one. Mostly it's like this. Every other lead, if you look at lead 3, you couldn't tell that there's any change.
No.
So really, I think it is probably just anodal stim, you know, capturing myocardium and depolarizing where that R prime comes from. Anyway.
I mean, to me, this scenario is the good news one, where the lower voltage is giving you the better QRS. You worry less about, you know, follow up over time. But I agree with Jackie. You know, if the lead isn't perfectly placed in the left bundle, sometimes you get a nice QRS with a higher voltage. But when you do a threshold, if no one's looking at the ECG, you might end up pacing at a lower voltage and end up with a wide QRS because you're capturing the septum without any of the conduction system. So
my argument here is I don't think it matters what output you have. It's all the same in terms of the pacing of the heart. I mean, obviously you want to turn it down to save battery, but I don't think it's having the R prime makes it, quotes, better.
I agree with you, but I'm saying if your lead is in this position, you're fine because you're capturing the left bundle the whole time.
Sorry, I misunderstood.
If you're adding the septum or not, I agree, is not relevant. The problem is when you only get a narrower QRS with the higher output, that maybe with a lower output, you lose conduction system capture altogether and you have only septal pacing. And that's something that in the clinic can easily be missed if an ECG is not being done.
Yeah.
Okay.
I have a comment just to be previous. Yes. So two things. First, if the acute threshold is lower than 2, as Atul says, always just at the end of the procedure, the threshold is going to be lower than 1. So I'm not taking any other measure to lower the threshold lower than 2.5 or 2 because it's going to be always better. For the future, I'm not sure exactly which one of these two configurations are going to low because there's more and more, mounting evidence that when you have this beautiful, right bundle like-ish block, maybe you're affecting the function of the right ventricle. So maybe the first one without the right bundle is going to be better to preserve biventricular function, but we don't know yet. So that's for discussion in the future. We're just trying to do the technique now, but in the future, we're going to debate which one of these two morphologies we want. And there's going to be some ultrasound and other strain or whatever things on ultrasound or left and right function to see which one is best.
I agree. I like the first QRS.
Oh, it's good. Generated a lot more discussion than I thought. That's great.
Yeah, definitely. Okay, here's the next one. This is again.
Yeah, so this is slightly odd. I don't really I want a little help with this. I didn't really understand this. So this is this was a case where we actually a patient with LV dysfunction had a heart block, and so we did a CRT, and the CRT had this 175 millisecond wide. I mean, he started, his sort of junctional escape was 140 milliseconds, and suddenly I got 175 millisecond CRT. So I decided to put a left bundle lead in. This is CRT P. I decided to put a left bundle lead in instead of the RV apical lead. I used a 3830 lead as the start of the CRT. And so this is just left bundle unipolar, and this is unipolar and bipolar. So this is a left bundle area lead. So if you just show the next, so if you see here, very tight LVAT, and here you still have a lovely R prime, you have a pretty narrow, but you have this big slurred, and the LVAT's much longer. And the only difference here is unipolar versus bipolar pacing.
So I'll go back to the other one. So that's uni, and this is bipolar.
How deep was the lead, Klaus? Like, was your ring in the septum as well, or was your ring a little bit outside the septum?
I must admit, I didn't recognize this till this was a follow-up ECG. Okay.
Okay.
So I personally don't do septograms every time. To be honest, I look at all the other. I look at my pacing parameters, and I don't ask them to open a bottle of dye just to, I don't find that. So I can't tell you that. So this was a follow-up, like 72 hours or a week later. This is something that I had not recognized in the operating room. So, yeah, I mean, the obvious question is it just not quite there? And with unipolar, I'm getting a bigger, distance that I'm depolarizing. These were, however, at the same outputs.
I'm going to show the next one because it was actually kind of cool. CRT plus LV, it was only 10 milliseconds less.
Yeah, exactly. So I mean, I didn't take the LV lead out. I mean, I just spent, 30 minutes putting it in. So it is and actually, interestingly, the best was when RV and LV were simultaneous. I must have, when I was scanning these, I threw out the wrong one, obviously. So it is actually about 20 mils. It is a tiny bit narrower with LV as well, but not much. It made me wonder, we're doing all these CRTs. Well, that's the next question, I guess, some study one day for this. So, but yeah, it didn't really make much difference. The interesting one was just the unipolar to bipolar. So I don't know if everybody just thinks maybe I wasn't quite deep enough, eh?
Yeah, that's usually what happens when you get, you know, with unipolar, you get sort of this beautiful classic, you know, selective left bundle type pattern. And then when you go to bipolar, suddenly you get this almost this pre-excitation slur looking thing, and it's not quite as crisp, and there isn't as much latency. It's usually just because you're not completely selective, and your ring may be outside the left bundle region, or part of your ring may even be outside the septum. And you know, only half the ring is capturing right at the corner of the septum. So I think that's probably what's going on.
Anyway, I mean, this yeah, and this is another one where I was spending. I had spent some time trying to get left bundle pacing, and I ended up. I tried all over the place. This person had you know, moderate LV dysfunction, and I ended up with this morphology. So I'm just throwing it out there. Is this an acceptable location? 2 minutes later, I didn't want to put too many. There is a small R prime that kind of grew over the next few minutes, and slightly more R waves, but still very diminutive little R waves. So I don't know, what would you, if you spent some time trying to get an LV, what are you going to do with this?
Go ahead. I was just going to say, like, just, you know, if you look at our recent publication with Santosh, and you look at even more publications coming out, you know, the QS pattern is not an uncommon pattern. You know, it's described in a certain percentage of cases that that's the best pattern that you can get.
Well, what about everything else? I mean, we have AVR and AVL. I mean, they're well, I guess AVR has a tiny dip down. But anyway,
no, but it's the initial part. It's the initial part of AVR and AVL that have to be dissociated. So they are actually dissociated.
Yeah.
Your QRS,
sure, but it's very inferior, I think.
Yeah.
Yeah, and your QRS duration looks beautiful. I mean, everything here looks good, and I'm sure your LVAT time was good too. You know, I'm just sort of eyeballing it here, but everything looks really, really good, with the exception of that V1 morphology. So,
do you often get this where you have no R wave across the entire precordial? This is the only case I've seen like this.
No, that's a little unusual.
Yeah, and I've seen ones where I think I'm inferior, and I'm, you know, sort of pacing the left posterior fascicle because it looks like classic left anterior fascicular block, but I've had a hell of a lot more R wave. Now, some, you know, I was going to throw in an ECG of somebody who had bifascicular heart block and had no R waves, like essentially this pattern. That was the native QRS, where left bundle pacing got rid of it. It went, the R wave came back. You know, it's like a normal R. Well, and the left anterior hemiblock's gone as well, but this didn't. It struck me as an anyway.
This looks overall like a more, you know, apical posterior implant. You know.
Yeah.
And which is, I think it's just as good, I would say. I mean, it's a beautiful ECG. Yeah. So
I, of course, decided I was going to try and do better than that, and that was a very bad idea. I can tell you that there was a long time went by, and before I finally got it. Anyway, so I think live and learn. So you guys would accept that as a
yeah, I would accept it. I think it's
amazing.
Lower and more apical, but still a narrow QRS.
And to do the stim to LVAT, are you taking it to the trough of the S in V6? I mean, what do you call an LVAT in that?
Yeah, I would go to the trough in V5. I mean, it's hard because, you know, usually V5 should be positive, and that's typically how the LVAT is measured. But you know, it's still an indicator of left ventricular activation time, right? So
Anyway, okay, well, I'm glad. Okay, so
I do believe a lot on the QRS area. So this is almost a normal QRS. So
yeah, no, it is astonishingly narrow, and after spending another, honest to God, 45 minutes or an hour trying to get another, I mean, I finally got it, but it was...
I had some few cases when it happened. Actually, I lost the R prime when I bump the right bundle.
Yeah.
You know, sometimes by, you know, working on the area, you bump the right bundle, you have a right bundle. And I get curious some few weeks ago, because after I bumped the right bundle, my R prime was no longer available. So I had this type of QRS. And I thought maybe because the right bundle has been bumped. Well, maybe that's why, you know, there's no way to have that morphology, but I don't know. So just
so it's an interesting.
Yeah, the R prime didn't bother me, because as you say, you do see that. But anyway, interesting. Okay, that's a.
And then here's there's like a double ECG here. So this is a pre-implant.
Yeah, so this is somebody, who had intermittent high-grade AV block.
Great. And here's another beautiful ECG close. Yeah.
Yeah, my question is, you know, people are measuring, this is like His measurements. I don't know. Do you measure from the spike? You're measuring leaving the latency out. Latency is kind of, I think, instead of fish stories, it's like bird watching stories. Yeah, it flitted by, you know, I saw that bird. That latency, you know, if you look hard enough, you can always measure 20 milliseconds shorter. And I guess I was just trying to stimulate some discussion about how people are honestly measuring latency, you know?
Yeah, like when you measure this from the spike, I mean, I guess the computer's measuring it from the spike, you know, but
so usually, sorry, go ahead, Jackie.
No, I was just going to say that, you know, usually when the pace QRS is usually about the same or just slightly longer or larger than your native QRS, like not bundle branch blocks, obviously, but in patients with narrow QRSs, I don't know. Guess you have you know, you're not stimulating the His directly, you're stimulating a little bit below. So you're not getting a perfect physiologic activation. And I think that you're probably losing a little bit of the RV activation with this QRS. But I mean, the question about where to measure it is actually very important, you know, for studies. I don't know.
Yeah, if you're going to do a study, that's right.
Right. Atul, what do you think? Where would you measure?
Well, so the classic, you know, papers have all left out the latency, right? So they're measuring the QRS duration from minus the latency. So the way we report it in our database is we report a latency and then we report a QRS duration. So, you know, the QRS duration, I agree, when you measure it on the ECG is sort of everything after the spike. So it kind of includes the latency. If your latency here was approximately, and again, I'm just eyeballing it, you know, about, you know, maybe 20, between 20 and 30 milliseconds, you know, then your QRS duration would probably be about, you know, 100 milliseconds. And, you know, to my eye, that's kind of what it looks like, you know. So I think for the purposes of a study or a trial, I would have people measure the latency and measure the QRS duration.
Measure latency? I guess that's when you know what lead, because some leads, let's say there is no latency really. You can always find leads that look like there are. You know, but if you look at all 12, you know, there's some that have anyway.
It's usually measured in V1 by convention. So, you know, whether that is the right place to do it or the wrong place to do it, but that's where it is measured. And, you know, for the purposes of our combined database with VCU, that's what we've agreed upon, is that latency will be measured in V1 and QRS duration will be separate from the latency.
Yeah, no, again, I mean, however you define it, I guess that's the important question, is that it's done consistently.
Consistently, exactly.
Yeah, I
Exactly.
think that's a
Nice.
really good point. I think maybe, defining or documenting the latency, how much that is, and then the QRS itself might be very helpful for perspective. Look at this.
I think these ECGs are cool. It shows the T-wave memory of the prior QRS. If you look 2-3 and AVF, have
Yeah.
Q waves at
Yeah.
the QRS negative. If you flip back to with the pacing, you show the next ECG again. The T waves are negative where the QRS was negative previously. It's kind of cool.
Yeah.
Francois, this is, I think you provided a few ECGs if you remember.
He chatted that he had to leave.
Yeah. Francois had to leave.
It's terrible. Okay.
But
We can keep going.
just by the way, these are all like terrific
I know.
ECGs, right? Like it's putting people to shame because these are like such good ECGs.
I already told you until I pulled the lead out of that one spot.
Yeah, but I mean,
so it's really stupid,
no, but these are all really terrific, and I don't know what Francois specifically was going to say about this, but this looks like a fantastic left bundle pace ECG. AVL, AVR are completely dissociated. You have a beautiful QR pattern in V1. The latency in V1 is not hugely long. This is closer probably to 20 milliseconds rather than to 30 milliseconds. But overall, very nice ECG.
But if you want to see latency, don't you often have to do it at very low outputs to kind of lose some of that septal capture?
Yep.
Yeah, but
Get
typically
the selective pacing essentially.
Yeah, exactly. But that all looked very selective to me. Like I can't imagine he was pacing at a very high output there.
Here's his next one. It's a different patient. Really. And then, this is his other one. There's a little bit more slurring here. It's an ECG, but I guess we could, in the next session, we could, look at these ECGs with him.
Yeah, go back one though, just out of curiosity. I mean, here it's interesting because I don't see very much latency at all. And it's interesting that if you look at the precordial, lateral precordial leads, V5, V6, you see a little bit of that upslurring that Klaus had been referring to before, right? And in V1, my guess is it's hard to say just from a television screen from a distance, but I would argue there's almost no latency there. And in fact, you're seeing a little bit of that down slurring, almost like a pre-excitation, and certainly in AVL and 1, you see that sort of delta wave type pattern as well. So I wonder if this is really as selective. I mean, the morphology looks nice, but and the QRS duration is pretty nice, but I wonder if this is really selective left bundle pacing.
I was going to say it looks like very distal His pacing. I mean, how you separate these out, becomes a somewhat. The other thing I've seen is a couple of times I've screwed 2 times. I've screwed deep. I did do septograms on these, and I did His bundle pacing. I mean, clearly His bundle pacing, unequivocally. 2 cases. I'm 10 millimeters into the septum, so I assume there's the occasional. I guess I don't ablate AV nodes, but I guess every once in a blue moon you have to go from the left side.
And then this is this third one. I mean, it would be nice to know what the ECGs look like before.
Yeah, that's such a good point, Jackie, because I was going to say this looks like I'm willing to bet this guy had underlying wide QRS conduction system disease before any pacing was done. This just looks like a sick septum,
Right.
you know, a sick conduction system. So it'd be interesting to know what the pre-ECG looked like here.
Yeah, this is actually Vidal's case. I didn't tell Vidal I was going to use it, but
This doesn't look very good pacing, Vidal. This looks awful, Vidal.
right now it's
I don't
before,
know
right?
what case
Okay.
she's talking
Okay.
about. This one or the previous one?
So hold on. So
I was joking, Vidal.
yeah, no. This is the presenting ECG, I think. Sorry, I may have mixed it up. So he's got a right bundle. Remember this patient, hold on. And then here he has some, fascicular disease as well as the right bundle. So you implanted him. And this was the presenting ECG with the nominal AV settings with sensitivity of, I guess, 150 milliseconds. And then this is it, when you're just pacing the ventricle here. But then look at such a beautiful result when you extended the AV delay, So I just wanted to bring this to everybody's attention, and I know Atul, you talk about it, but, to maybe fiddle around a little bit with the AV delays to make sure that you really optimize fusion pacing.
Yeah, because if you can entrain a little bit of the natural right bundle, whatever's left, and then also capture the left bundle, it's like you said, you get that beautiful fusion between the two, because I realized that there was a baseline right bundle branch block, so you could say,
Right.
well, the right bundle, there's nothing conducting down it, but that conduction block may be quite distal. So if you can lengthen that AV delay, give a little bit of a chance for that proximal right bundle to depolarize, and then fusion pace at the correct time with the left bundle, it's gorgeous. Like it's like truly physiologic pacing. So changing that AV delay is an important thing to consider, especially when you have kind of these sick diffuse conduction system disease patients like this one, this case DA. That pre-ECG was awful looking. There was a lot of conduction system disease. And, yeah. And so if you just give up without optimizing the AV delay, you'll end up with your DDI morphology, which is still a huge improvement over, what you had before, but it's still not optimal. And, when you sort of play around with the AV delays, you can really.
Yeah, so I guess comment and confession. I think I remember the case now. Comment is, I strongly believe in fusion pacing, and I think that when patients have intrinsic conduction, the AV delay timing is important because you can benefit from the intrinsic conduction. But in this case, I think this was a patient where there was an attempt at a septal lead position that spontaneously dislodged onto, I think, most likely the RV free wall, and basically allowed for a CRT, if you will, of the right ventricle. And by adjusting the AV delay, I was able to correct the right bundle by pacing on the right side to fuse with his intrinsic conduction. But I don't think the lead was anymore in the conduction system at that point.
Wow.
Oh, that's even more interesting.
So it was like a unintentional CRT of the right ventricle to correct the right bundle with the RV basolateral position of the select securely.
Yeah,
sometimes you need to give beta blockers, just to delay the normal AV conduction, to allow the any wherever right or side or left-sided branch to recover enough to conduct smaller, but nice case.
Yeah.
Yeah, very nice case.
There's a bunch more. I mean, I don't know. We could keep going or 7:30. I don't know.
Yeah, I think it's 7:30, Jackie. So probably we should save these for the next session.
Right.
You know, I think thank you all for joining. I mean, hopefully people find this educational, and as always, the purpose of this is not just to you know, have experienced users joining in, but also to have inexperienced users who maybe are interested in starting this, or maybe they'd want to, you know, try some cases. And so the idea here is really to encourage everybody to try this and to get working on this. And you know, we'll continue to have these sessions where we continue to review the technique and also review cases, and we may even see them in 3D.
So this is just because, you know, I asked everybody to give me their nicest ECG in it, and this is the winner, because look at these crazy T waves. So Jean Champagne provided us with this ECG. It's really nice.
Very nice.
All right.
Great.
Good.
The 2 ways really just mean the memory of what was going on there before. So
Yeah, exactly. Exactly. That's right.
Well, thank you very much. Great. Thanks for organizing, guys.
Yeah.
All right. Have a good
Thanks.
evening, everybody.
good night.
Okay. Bye-bye.
Thanks, guys. Bye.